audible?
Yes. Yes, you're
Slides
audible.
visible ആണോ? Slides visible ആണോ?
The slides visible ആണ്.
Okay. Today we will be understanding the tachyarrhythmias. Tachyarrhythmia, usually you all know the tachycardia definition. The heart rate is more than 100 beats per minute. When analyzing a tachy ECG, you should have at least 5 points should be looking into the ECG to tell what the arrhythmia is. Before that, we should understand there are tachyarrhythmia. There are two types: wide complex tachyarrhythmias, in which the QRS complex is duration is more than 120 millisecond, and narrow QRS tachycardias, narrow complex tachycardias, that is QRS duration less than 120 millisecond. So first, we'll understand the hemodynamics of tachyarrhythmia symptoms. What are the danger signs of tachyarrhythmia, serious tachyarrhythmias? So you all know cardiac output is equal to stroke volume into heart rate. So in tachyarrhythmia, essentially the heart rate goes up. The symptoms will depend on how much the heart rate will be high, because the heart fills during diastole. In tachycardias, the diastole, the filling period of the heart will be shortened. So the heart effective filling of the heart is impaired due to high heart rate. The forward cardiac output will be affected. So the heart rate goes up, stroke volume goes down. So cardiac output also will be impaired or will be maintained. So the tachyarrhythmia, which is very fast, faster than the physiological limit of a person, usually 220 minus age. For a 50-year-old man, he can accelerate his heart rate up to 170 if he is in a normal physiological condition. So above that, only usually he will decompensate. So the tachyarrhythmia, which is very faster, up to 180, 200, 220, will be impairing the cardiac output, causing symptoms. So what are the symptoms that impaired cardiac output due to tachyarrhythmias? So as there is what are the warning signs of a serious arrhythmia? So red flag signs of a serious important arrhythmia which should be taken care of is as always a loss of consciousness, as a syncope or giddiness. Patient is unable to maintain the posture, so he will be having some form of fatigue, so that he have to sit down, he will be sweating around, or he'll lose his consciousness, or he will be in pulmonary edema. How will you know pulmonary edema? The patient will be relatively stable. He will be having some sweating and sudden desaturation with the signs of lung congestion. These and patient who is experiencing angina during these tachy episodes also having a red flag sign. So these are the signs. These are telltale signs, red flag signs of a patient who is having a very high heart rate, who is going to decompensate, needs urgent care. These are the signs: syncope, pulmonary edema, or angina. And these are the symptoms where cardiac output is compromised during a tachyarrhythmia episode. Not all tachyarrhythmias are dangerous. We will be going from in an order that first we will be dealing atrial arrhythmias or narrow QRS tachycardia, which is relatively not very dangerous, to a wide complex tachycardia like ventricular tachycardia, ventricular fibrillation, which is very life-threatening. So can anyone tell me about the ECG diagnosis?
Slide visible അല്ല
ഇല്ല
തോന്നുന്നു.
പറയാം ഒന്നുകൂടെ ഇപ്പോഴാ ഷെയർ
ഇല്ല കാണത്തില്ല. വരുന്നുണ്ട്.
പറഞ്ഞു. First I will be telling about how to assess a tachycardia ECG. First the rate.
ഫുൾ സ്ക്രീൻ ആക്കാവോ?
ഫുൾ സ്ക്രീൻ ആക്കല്ലേ? ഓക്കെ ഇപ്പോഴോ?
കാണാം.
ഓക്കെ. This what is the rate P wave relation to QRS, the QT, the intervals, PR interval, QRS duration, QT interval, like that. STT changes like that. You have to assess a tachycardia ECG. Is it a regular? Is a wide complex or narrow QRS tachycardia? That's the first thing you do.
Narrow.
It's a narrow QRS tachycardia. So the QRS duration is normal. It's less than 120 milliseconds. So it's a narrow QRS. And the heart rate is how much? It's around 100. Just above 100. 101 or 102. It's a tachycardia. It's a narrow QRS tachycardia with the 1-to-1 AV conduction. The P wave is normal. PR interval is normal, and P wave is followed by QRS. All P wave is followed by QRS. P, QRS, P, QRS, P, QRS. And the RP, there is always RP interval. There is long, because tachycardia, the P wave, where the P wave falls is also important. So along with PR interval, you can always see the R to P interval also. So this is also a long RP, narrow QRS, long RP tachycardia with 1-to-1 AV conduction. Usually this is sinus tachycardia. This is the most common tachycardia we come across during our clinical practice. So this is very benign. This is very normal one. So what are the causes of sinus tachycardia? You will all know normal response to sympathetic nervous system, increase in metabolic rate. What are the etiologies? Usually caffeine, smoking, nicotine. Medical conditions, you have to rule out anemia or any bleeding, hemorrhage, fever, hypertension, pain, and or medication effects like central stimulants. Or patient will be who's a heart failure patient who is having acute decompensation will also be having sinus tachycardia. Always sinus tachycardia range will be around 220 minus age usually for a patient. So you can always think if the heart rate is 140, the patient age is 50, and who is having some anemia or some distress, always will be sinus tachycardia, and you have to find out the cause. Don't have to search for the arrhythmia as a look behind the arrhythmia. It will be a secondary problem which will be causing sinus tachycardia. So this is very commonly we find out during our clinical practice. So that's all. Then we will go to atrial arrhythmias. The atrial arrhythmia impulses arise outside the sinoatrial node. So you will be knowing SA node, AV node, his system, his bundle, then followed by left bundle and right bundle to Purkinje fibers. That is the order of conduction. Apart from SA node, if the impulse can arise any from the atria, producing a P wave of different morphology. So it can be a premature atrial contraction, paroxysmal atrial tachycardia, or atrial flutter, atrial fibrillation. You'll be seeing one by one. So can anyone see the ECG and diagnose? Can we go one by one with the P wave, like QRS first rate, QRS duration, whether it's wide or narrow QRS, P wave morphology, PR relation, then in intervals, PR, QT intervals. Like that, you can see the tachycardia ECG. Can anyone report the ECG and finally tell the diagnosis also? Actually, some of these things are already highlighted in this ECG. What's the problem? You can see the rhythm strip, lead 2. This is actually narrow QRS tachycardia with 1-to-1 AV conduction, P wave followed by QRS in all beats, and P wave morphology is slightly different in between the beats, 1 or 2 beats. And the coupling interval, RR interval, also varies when there is a P wave with altered morphology. This is atrial premature contraction, which is coming in between. This is one. So the P wave morphology is entirely different. The PR interval is different, the RR interval is different. And the post PVC, there is some pause is there. And rest of the P wave will be almost the similar one. So this is a atrial premature contraction. So most common ectopic beat in impulse is generated from the away from the SA node. So abnormally shaped P wave QRS complex is not affected. Can anyone tell this is the commonest tachycardia, abnormal heartbeat, heart rhythm we usually see in our clinical practice. So all we are aware of it. We will slightly understand little about all these things. Can anyone tell about this ECG diagnosis?
SVT. SVT.
SVT. Can you read the ECG? Is it a wide complex? What is the heart rate? Is it a physiological limit?
Narrow complex.
What year? A narrow QRS. And the heart rate is around?
Oh.
Some 210, 220, something like that. Very high heart rate. It's not in physiological range. So it's a pathological tachycardia, narrow QRS. Are you seeing any P wave or PR relation or anything like that?
No P wave.
No P wave seen. Okay. Then okay, this is a SVT. What is the immediate treatment when you see a patient with a SVT, narrow QRS tachycardia?
Adenosine.
First, you have to give a vagal maneuvers. Vagal maneuvers, like you can tell the patient to do Valsalva or you can do dip the face
Carotid massage.
or like that. First, Valsalva. Usually, most of the patient will be reverting with the Valsalva maneuver. You can teach them when the tachycardia comes. Some patient it will be not responsive. In that case, we will give adenosine. And some of this tachycardia may not be responsive to adenosine also. We will understand a little bit of the mechanisms. This ECG can be AVNRT, AVRT, all those things. It's general coming as SVT, and it's a narrow complex tachycardia, which is very well tolerated by the patient. Only symptom of tachycardia. There will be no warning signs with this patient with the SVT, like pulmonary edema. Unless patient is having LV dysfunction, they will not have pulmonary edema with SVT, or they will not have syncope with SVT, or they will not have any other angina unless there is coronary artery disease. They won't have angina also with the SVT, even if there is STT changes are there. Okay, there's ST depressions are there, but it does not indicate. Usually, it does not indicate ischemia. Usually, some patient if you have coronary artery disease there, that can precipitate STT changes. And usually AVRT will have significant ST changes. So this I will be showing these images. This was taken from YouTube. Actually, these are the mechanisms. Just to show you how the AVNRT comes. You can see this is AV node. This is SA node. This is AV node, and this is his bundle, left and right bundle. This is the interatrial pathways, Bachmann bundles like that. So how the SVT works, we'll be seeing that. So this is the normal conduction. This is the ECGs. You can see the yellow, where ECG SN P wave followed by PR interval, followed by QRS duration. So the normal activation pattern, and followed by when there is a tachycardia happens. This is the tachycardia. This is the tachycardia started to happen. Here is the circuit. You can see this yellow thing is circuiting around this. Here is the fast pathway and slow pathway, and the current is circuiting between the fast pathway and slow pathway and sending signals like up and down. So the P wave will be coming at the same time the QRS is coming. So that sometimes if it's so fast, we will not be seeing any P wave, only QRS coming in between. That's why in usually AV and AV NRT will not be seeing, we'll be seeing short RP interval, short RP tachycardia. Because you can see in this one, when tachycardia started happening, the P is coming here, QRS and P. So here, whatever circuit, the circuit is coming here, and it is sending signals P wave same time as well as QRS same time. So we will be seeing P QRS followed by small p here. So short RP interval, short RP tachycardia. Sometimes P will be inscribed in the QRS, so P will be absent also. So this is the mechanism where AV and RT happening, tachycardia. And AV RT usually will be seeing a accessory pathway somewhere here. That is, accessory pathway means apart from the normal heart, the atria and ventricles are connected through the fibrous trigon through the AV node to this bundle. But in some myocardial sleeves will be persisting embryonically, and that will connect the atria, that will bypass, that will short circuit the atria and ventricle like this. There will be a connection. So whatever impulse coming here will not go through the AV node, that will go through the AV node as well as through the accessory pathway here. So the ventricle will be activated from here also, from here also. So there is a pre-excited ventricle, and if the tachycardia happens, the circuit will be like this. And here the circuit is very smaller one. But in AV reentrant tachycardia, atrioventricular reentrant tachycardia, you will be seeing the activation pattern like this. Here is the yellow thing you are seeing in the mitral valve is the accessory pathway. So when the tachycardia happens, this will be circuiting like this. This yellow thing will be circuiting like this. So that is the circuit in a AVRT. So it's a very big circuit, not a revolving around the AV node. It will be atrioventricular tachycardia. And the findings ECG, it will be almost the same thing, but ventricle and you should not be usually seeing a short RP. The P will be within the QRS, and the STT changes because my ventricle is involved in the circuit. The STT changes will be profound. STT changes will be profound in AVRT. And this way you will be finding out the AVNRT, AVRT. I think you will be, you just understood. Can any further clarification needed in this? Did you understand the basics of AVRT, AVNRT? Both the circuit. One AVNRT, there is nodal circuit is revolving around the node. The AVNRT, it's atrioventricular, atria and ventricular affected. You will know paroxysmal supraventricular tachycardia, AVRT, AVNRT, palpitation, neck pounding. There will be no difference in between the treatment also, because both are common area affected is node. So if we block the node, the circuit will be broken, and the patient will be having relief of tachycardia. So treatment is carotid sinus massage or any vagal maneuver, so that the AV node will be having a negative effect, so that conduction will be stopped. And IV adenosine with rapid bolus, beta blocker, diltiazem, verapamil, everything will work in these patients. Can anyone read the ECG? Is it a tachycardia? What's the relation? P wave, morphology, PR, AV, PR relation, RR interval, PR interval, QT interval, like that.
So 8 is more than 100.
Yeah. This is narrow QRS tachycardia. Is the P wave, is morphology of P wave is anything different from usual P wave morphology? So you can see the P wave is negative in 2,3 AVF. Usually it is positive in 2,3 AVF. So you can see the atria is activated from the inferior part of the atria, and then it goes up. That's why negative in inferior leads. Because inferior leads, it's away from the inferior leads, so it is negative. And this tachycardia, so it's ectopic atrial tachycardia. The focus of the atrial tachycardia is coming from the inferior, maybe from low atria, coronary sinus, or somewhere around that tricuspid annulus area, like that. So this is ectopic atrial tachycardia, which is most commonly seen in patients with congenital heart disease, or post-operative patients, or patient with sick sinus syndrome. All these patients. All this group of patients will have a ectopic atrial tachycardia. It's a type of tachycardia which is narrow or QRS. Patient will be having palpitation symptoms, and at the most, if they are long time, they will develop tachycardiomyopathy like that. If the patient tachycardia goes on like for some time, most of the beats are tachycardic. Their LV dysfunction, they will develop an LV dysfunction. That LV dysfunction, that complex syndrome is called tachycardiomyopathy. That is a reversible cause of cardiomyopathy. So if you treat the tachycardia, their LV function will recover. So very important in finding a patient with atrial tachycardia, atrial arrhythmias, these arrhythmias which is coming very frequently, that will cause LV dysfunction set in after some time. So those patients, arrhythmia recognition and treatment with a drug like amiodarone, or sometimes if incessant treatment, you can go for a catheter ablation so that their LV function improves with a proper treatment of the arrhythmia. That is important in understanding these arrhythmias in patients. Ectopic atrial tachycardia. This is paroxysmal tachycardia, you all know. This is the pictorial diagram. You see, usually the SA node is firing, but here you can see the left atrium is started firing, and it is activating the ventricle. So this is ectopic atrial tachycardia. Somewhere from the SA node, this tachycardia actually faster than the sinus nodal rate, so that sinus node will keep suppressed, and the LA focus is taken over the heart, and it will beat the heart in a faster manner, 120, 130 like that. Even in the sleep also it will be like that. So the patient will develop reversible LV dysfunction later. So identify this arrhythmia, treat this arrhythmia, will conserve the LV function. Can you even tell the diagnosis of this ECG? So, is it a narrow QRS? It's a wide QRS. Is it the P wave? What are the P wave more than a V wave, or P is equal to V? Or what is the relation between P to QRS? Like that. Can anyone attempt the diagnosis?
ഫ്ലട്ടറാണ് ഫ്ലട്ടറാണ്
Atrial flutter, correct. So atrial flutter, because you can see the sawtooth pattern in the P wave. Actually, what is the difference between, how will you have different flutter with atrial tachycardia? Both are having multiple P waves. P wave will be more than the QRS. That is a catch in this. Atrial arrhythmia usually will have P wave more than, it will be 3 or 4 P waves, or sometimes 2 P wave for a QRS. So how will you differentiate tachycardia with this atrial flutter? Both are having multiple P waves before the QRS. So how will you differentiate this sawtooth pattern? There usually the method is to find out there will be no isoelectric line between two P waves. In atrial tachycardia, there will be a presence of isoelectric line will be there between two P waves. But in flutter wave, there will be sawtooth pattern. There will be not be any isoelectric line between these two. This is multiple P waves, and it will be and atrial flutter. We will understand atrial flutter tachycardia circuit now. So this is a correct diagnosis of atrial flutter. Atrial flutter can come from different areas and have different morphologies. There are typical and atypical atrial flutters are there. The typical atrial flutter, there is counterclockwise and anti-clockwise loop is there. This is a atrial flutter. Then this is a circuit for atrial flutter. This is hormone sinus. This is the atrial flutter loop. This is the one tachycardia circuit for a atrial flutter. Here, usually this atrial flutter happen in patient with a congenital disease, who is having tricuspid regurgitation with a large right atrium, or who is having a post-operative where the atria is cut for the approaching the cannulation. All those patients, or congenital surgery where atriotomy is done for the VSD closure and all those things. In that patient, there will be a scar here. Through that scar, there will be a normal sinus normal area around that scar will conduct impulses like this, and they are forming a circuit, and the tachycardia ongoing. Tachycardia will be fluttering like this, so multiple atrial atrial beats, P waves will be there, followed by 1 or 2, 3, or after 3, one will be going down through the AV node and will conduct as a QRS. So this is the circuit of one type of atrial flutter. This is the circuit of one type of this is cavern tricuspid isthmus. And then there are multiple things are there from LA. There can be LA flutter is there. Then it can be around the SVC upper circuit is there. And then it can be around the septum. So everywhere it can arise around a scar. So this is the type of atrial flutter. This is the circuit, multiple atria, there will be circuiting like this. And sometimes it will be sending impulse to the QRS in 3 or 2 beats. Sometimes it will be one-to-one conduction. The ventricle also will be beating very faster, and the patient will be very symptomatic. Can you tell the diagnosis? This is very clear diagnosis, very common diagnosis of atrial arrhythmia. It's one type of SVT.
Atrial fibrillation.
Very good, atrial fibrillation. There is no absent P waves and varying RR interval. Okay, you will be seeing atrial fibrillation. What happens to atria at the real time? So this is the here is what is happening to the atria during atrial fibrillation. So the atria will be fibrillating. There is no contractile force from the atria. So the atria will be just will be fibrillating like a bag, and there is contractile function not there. There is only reservoir function, and the ventricle and the valve opens, the blood fills to the ventricle. And this atrial fibrillation, there is continuous bombardment in the AV nodal region, and 1 or 2 will be conducting. So the AV node will selectively conduct 1 or some beats, so the ventricular rate will be maintained. If conducts we will see a patient with atrial fibrillation with a very fast ventricular rate, patient will be in pulmonary edema if he is having LV dysfunction or diastolic dysfunction, or the patient will be in shock also sometime. The ventricle is diastolic dysfunction, or ventricle is severely dysfunctional. So the atrial fibrillation, from here we can see atrial flutter, atrial fibrillation, that can decompensate the patient if the heart rate is very high. The ventricular conduction is very high. So this patient needs urgent cardioversion in atrial fibrillation. If the patient solely in patient in atrial fibrillation, very high ventricular rate with blood pressure, low blood pressure, and patient is in pulmonary edema, or some patient is having angina, or patient is decompensating. At that moment, you have to revert the atrial fibrillation. You have to give DC cardioversion, or if the patient is hemodynamically stable, you can start on amiodarone. This from last 2 arrhythmia, we have seen atrial flutter and atrial fibrillation. Both can leads to high ventricular rate. Fast ventricular rate can decompensate the patient. One thing in atrial fibrillation, there is no effective contraction of atria. So clot can form in the atrial wall, free wall, in atrial appendages, all those, because atria is not contracting and relieving its content. Atria is just fibrillating. So clot can form in the LA appendage or in LA free wall. So this can embolize and cause stroke. That's why in atrial fibrillation patient, you have to assess the stroke risk by CHA-2-VAS score, and you have to anticoagulate them if the score is high, more than 2. But that's why, because the atria is fibrillating and the clot can form in the atrial wall or in the LA appendage, can cross the mitral valve, go to LV and go to aorta and go to cerebral circulation, can cause stroke. So in a patient with atrial fibrillation, you have to assess stroke risk, and first you have to assess the hemodynamic stability, revert the patient, and find out what causes atrial fibrillation. Treat the underlying causes. If no cause found, it's non-valvular atrial fibrillation. You can stratify the patient for stroke prevention, like that. Can anyone tell what are the most common causes of atrial fibrillation we see in our practice? Age-wise, if a young man presents with atrial fibrillation, and a 50 plus and a 90 plus. 3 ages, if they have atrial fibrillation, what are things you have to look for as the treatment of atrial fibrillation, cause of atrial fibrillation? This is a very common arrhythmia. In a young patient, this atrial fibrillation usually valvular heart disease, rheumatic heart disease, mitral stenosis, mitral regurgitation, channelopathies, congenital heart disease like mitral stenosis, aortic stenosis, large ASDs, or other congenital heart disease like transmissional gate arteries and like that. Eisenmenger syndrome, untreated congenital heart disease. In an old age patient also valvular heart disease, then non-valvular atrial fibrillation and atrial cardiomyopathies, atrial channelopathies can cause atrial fibrillation. Then pacemaker induced sometime patient who is having pacemaker will develop atrial fibrillation later. Then diastolic dysfunction from obesity, hypertension, all those things can lead to then the hormonal endocrine causes like hyperthyroidism, very common cause of atrial fibrillation. Then post-cardiac surgery, post-device closure, myocardial infarction can cause atrial fibrillation. Multiple things are there for atrial fibrillation. So atrial fibrillation is so common, will have a usually underlying cause. So you have to find it out. Atrial fibrillation, you have to stratify for stroke also. So now we are going to ventricular arrhythmias. Till now we've seen whatever QRS duration was narrow QRS tachycardias. From first atrial premature contractions to some atrial arrhythmias, we have seen atrial tachycardia, atrial fibrillation, and atrial flutter can cause a decompensation if the ventricular rate is high. If the ventricular rate is controlled, they will be tolerating, only will have some symptoms. They are not tolerating, then you have to decivert them or give a quadron. Then stratify all these patients because atrial contractile function is lost in atrial fibrillation. And sometimes this atrial flutter can also will predispose to development of atrial fibrillation. So you have to stratify these patients for stroke and give anticoagulation if they are at high risk of stroke. Now we will go into ventricular arrhythmias. In ventricular arrhythmias, impulse originated, all these impulses were originated till now, narrow QRS originated from atria and it was circuiting in the atria, but all this coming through the AV node down the Purkinje fibers. So it's a conduction system, but in ventricular tachycardia, so that's all where narrow QRS tachycardia. But in ventricular arrhythmias, the impulse originates in the ventricle and conducted upwards. So its all will be it will be conducted from myocardium to myocardium. Finally, the Purkinje cells will be captured. So it will be wide complex. The QRS duration will be very wide, and the initial deflection of the QRS will be wide. It will be usually more than 100 millisecond usually. So ventricular arrhythmias you can see. Now you will see some of the ventricular arrhythmias. Impulse originate in the ventricle. Usually ischemia is the most common you see in our practice. Can anyone say what is this arrhythmia? This is a tachyarrhythmia. This is a ventricular arrhythmia. There you can see that a broad complex ventricular. This is an narrow QRS which is conducted from the SA node to AV node to QRS. This is a conduction system. Proper conduction system activation of the ventricle followed by there is a ventricular ectopic beat that activated the ventricle retrogradely, and then there is a compensatory pause followed by QRS, and this is coming in a bigeminal fashion. So this is a ventricular bigeminy. This we can see in between In usual practice also is very commonly seen. Usually in patient with dyselectrolytemia, we usually see this kind of findings. And without any structural problem also we can see this kind of arrhythmias. All premature ventricular contraction will have compensatory pause, QRS complex wide. It can be single morphology or multifocal, different morphologies. And you have to this can be associated with arrhythmias also. When you see this QRS complex which is wide, this is T wave. If this comes and falls on this T wave, this is the ventricular refractive period. This can initiate a torsade, a ventricular tachycardia, torsade rhythm. So when you see a ventricular premature contraction, we can stratify that whether it will produce a arrhythmia, because if it falls in the T wave, R on T phenomena, then it can cause a torsade rhythm or it can go to ventricular tachycardia. So some you can see why the morphology of the VPCs, we can predict from where it is coming. And is it a high risk VPC, like is it fragmented VPCs, multifocal VPCs? VPCs come from different parts of the heart. And if it is having short coupling interval like ROT, like in ischemia, Purkinje fiber and VPCs, short coupling interval will be there. In that cases, it will be higher risk VPCs. So from simply looking at the VPC itself, we can tell is it a high risk VPCs. But in this case, it's not. It's a outflow VPC with the compensatory pause. There is no ROT phenomena. There is no, this only all coming from the same area. So it's a unifocal VPCs. There is no fragmentation of the VPCs also. There is no scar related to it. Anyone tell about this ECG? This is a very important ECG. From here onwards, we are seeing all the serious arrhythmias. And you should be able to tell is it a confidently, is it a ventricular tachycardia or it is a SVT with aberrancy? That is the usual question coming in our mind when you see a broad complex tachycardia. You see, it is some easy algorithm I will tell you about where we can find out whether it is a ventricular tachycardia or SVT with aberrancy. Can you attempt or read this ECG?
Torsade D pointers.
No, this is monomorphic. Monomorphic VPC. This is a single. This is monomorphic. Torsade is polymorphic. This is just to read this is a broad complex, regular or irregular. Regularity is important in broad complex. In narrow complex also irregular is very important. This is it a broad complex? Is it a regular? Is there is any AV conduction, any AV dissociation is there? Is it a regular tachycardia?
Regular.
So, regular tachycardia, regular broad complex tachycardia. Regular broad complex tachycardia will have always, mostly it will be VT, mostly. In a structurally abnormal heart like history of CAD, coronary disease, or some heart disease in the past, with a regular broad complex tachycardia will be usually ventricular tachycardia, and sometimes it can be SVT with aberrancy also. So we have to see some of the features like axis. If you have a patient with a ECG available, previous ECG available, you can just see the axis of the newly formed tachycardia. This is a broad complex tachycardia. AVF is negative. 1 is negative. So it's extreme axis. So it's a axis is on somewhere in -180 to -9 like that. So it's a extreme axis. So it's coming from below to up. So it's a different axis. Those different axis difference. Then AVR positivity. AVR is positive. This positive. AVR is positive. and there will be only QS or R, only positive waves in V1 to V6 or negative waves in V1 to V6. There will be only there will be transition in all normal heart. There will be transition. V1 will be negative. From V1 to V6, if you go some negative and small negative, then V4 to V3 to V4, there will be positive waves start coming, and V5, V6 will be positive QRS. That is some normal transition pattern in a normal heart. But in patient who's having VT like apical or basal VT arising from the apex or on the base, that concord, that transition will be lost. So V1 to V6 will be having either only positive wave or either only negative waves. In apical VT, we will only see negative V1 to V6, all negative waves, V1 to V6. If you see like that, concordance pattern only in V1 to V6, that is more likely VT. AVR positivity will be VT. Then axis shift from the baseline ECG, that will be usually VT. And you can see fusion beat, AV dissociation, fusion beat, capture beat. If those things are there, that indicates AV dissociation. That also highly suggestive of ventricular tachycardia. If you see all these four, you have to. It's very easy to look at all these things. If you see all these things in a ECG, it will be 100% ventricular tachycardia. It won't be SVT with aberrancy because AVR positivity, axis shift, concordance in V1 to V6, only negative or positive in V1 to V6. There is AV dissociation in the form of fusion beat or capture beat, like that. And then you can see AV dissociation in between also. P wave in between falling on the QRS also we can see. So in this ECG, actually, we are not seeing any fusion beat or capture beat. If you really see some notches here, that will be P wave will be falling in between here. It's not constantly falling in a single place. It is falling in some different places, multiple, and always in VT, there will be more V than PB, more QRS than the P waves. So P will be some falling in some between, and there will be QRS waves. And if any narrow beat is present, it will be a capture beat that indicates AV dissociation. Fusion beat will be a mixture of a narrow complex and the broad complex. That is a fusion beat. That also indicates some beat from the below. Ventricle will goes up and collide with the P wave conducted through the AV node and form a fusion beat. That indicates AV dissociation. AV dissociation means ventricle is firing, atria is firing. There is no relation between the firing of atria and ventricle. And some beats, the atria gets through the AV node, that will fuse with the ventricle beat called my fusion beat. That indicates AV node dissociation. So ventricular tachycardia, regular broad complex with the features of AV dissociation, and the other features I told you, negative concordance or positive concordance in V1 to V6, positive AVR, and axis shift, and initial and one thing also you can see the initial R to S duration, RS duration, because the ventricular, this VT is activated through the ventricular myocardium, not through the conduction system. So the initial part of the RS complex, this is R, this is RS complex will be wider, more than 100 millisecond it will be, more wider, 40, one is 40. So it is more than 100. That also indicates it is conducted, it is activated through the ventricular myocardium, not through the conduction system. So the activation front starts from the ventricle. And the ventricular tachycardia definition is 3 or more premature ventricular contraction in a row, meeting the ventricular discharge rate of around 100 to 250 millisecond. Usually we see in myocardial infarction, electrolyte imbalance, or patient with reduced heart failure with reduced ejection fraction. Here is the VT activation pattern. You can see the SA node activates the AV node, but some part of this area of the ventricle started firing autonomously, and it is activating the ventricle. Here, it's activating the ventricle entirely, causing tachycardia, white complex tachycardia to run. And if it sometimes some people it will be they will tolerate the ventricular tachycardia, BP will be stable. In that patient, you can give only amiodarone. And if this can degenerate into VF sometimes. So in that patient, you have to DC cardiovert. The patient is having LV dysfunction, they will be sick, hypertensive. In that case, also you have to synchronized DC cardioversion should be given for these patients with ventricular tachycardia. Here the ventricle activates and causing that the ventricle contracts fast. So the treatment, if stable, continue monitoring, obtain tolerable ECG, factor determined medication to be administered, monomorphic or polymorphic, existence of prolonged QT interval prior to onset, LV function, amiodarone bolus infusion. Why monomorphic and polymorphic? Monomorphic we have seen just now. Now next we will see polymorphic QT. And there you have to see the initiating, if you get an ECG of an initiating event of a QT prolongation just prior to initiation of VT. In that case, it is usually followed by a drug-induced, usually a drug-induced or a dyselectrolytemia. Drug-induced or dyselectrolytemia. These two usually you have to rule out because the patient inpatient usually they will collapse fastly with a arrhythmia. You have to usually we will have either diarrhea or a magnesium depletion or a hypokalemia in that patient. In some patient, in those patient who is receiving any psychotic medication or QT prolonging drugs, antibiotics, fluoroquinolones or quetiapine or other antipsychotic drugs which can prolongs the QT. Levofloxacin also can prolong the QT. That patient who is having a diarrhea, who is having a magnesium depression will have QT prolongation, and if VPC coming on that will cause a torsade rhythm to start and the patient will suddenly collapse. So this initiating event, or if you can catch in a monitor or in a ECG, then it can also, in that case, the treatment is different. You can always administer magnesium rather than giving a amiodarone. You can always shock the patient. You can replenish the drugs, or you just increase the heart rate with pacing or something like that. In that case, this QT prolongation will be normalized. Usually antiarrhythmic drugs won't work in that situation. That's the difference when you give antiarrhythmics. Amiodarone in some patient with QT prolongation with torsade, you just shock the patient, load with magnesium, increase heart rate either by pacing if they're not responding to the treatment, or you can give isoprenalin also to shorten the QT. That's all those things. So can anyone tell this arrhythmia? This is a thing you told just now, torsade. This is some polymorphic VT twisting around points. This is a thing where there is zero cardiac output during this arrhythmia. So patient will definitely collapse, zero BP. If you find out promptly and DC cardiovert and intubate, rested the patient usually come back, and you have to treat the underlying cause like the dyselectrolytemia, drug-induced QT prolongation, or any other. Sometimes it will be myocardial infarction in the anterior territory, or LMCA occlusion will precipitate like that. So prompt resuscitation and treatment of underlying causes, we will treat the patient. This ventricular fibrillation is rapid disorganized ventricular rhythm that is an infective contraction of the ventricle. No atrial activity on ECG. This is the where a ventricle fibrillates. When the ventricle fibrillates, there is no forward cardiac output. The patient will be having zero blood pressure, no pulse palpable. It will be code blue. Then you have to resuscitate the patient and find out the cause. Load with magnesium, DC work. And if the heart rate is low with prolonged QT and the resuscitated ECG, you should increase the heart rate to either give isoprenalin or temporary pace, put a temporary pacer on the patient, like that. Or give isoprenalin also. That will help to reduce the QT. And you can start beta blocker once the patient is stabilized. And okay. Usually we will see in MI undergoing electrical shock Brugada syndrome or like that. So treatment of ventricular fibrillation, immediate defibrillation, activation of emergency CPR as antiarrhythmic drugs treat the cause cardiovascular fibrillator. You have to see where this usually when you put paddles, you apex and at the right sternum, so the if the artery is dilated also, that will be coming in between the electrical circuit, so the entire heart will be covered, so you can effectively DC cardiovert the patient with this one. If you keep above the left, usually if the artery is dilated, you will miss that area, so atrial arrhythmia will recur usually. If the atrium is dilated, you just put on the right chest, right sternal border and DC vert. Any doubt, please ask.
പാർട്ടിസിപ്പൻസിനെ അൺമ്യൂട്ട് ചെയ്ത് ഡൗട്ട്സ് ചോദിക്കാം. അൺമ്യൂട്ട് ചെയ്ത് ക്വസ്റ്റ്യൻസ് ചോദിക്കാം. ഒരു ഇമ്പോർട്ടന്റ് ടോപ്പിക് ആണ്.
സാറ് ആർക്കും ഡൗട്ട് ഇല്ല എന്നാ തോന്നണേ. കാരണം ഇന്ററാക്റ്റീവ് സെക്ഷൻ ആയതുകൊണ്ട് അപ്പൊ കാര്യങ്ങൾ പറഞ്ഞു പോകുന്ന വരണ്ട് ആർക്കും വലിയതായിട്ടുള്ള ഡൗട്ട് ഇല്ലാന്ന് തോന്നുന്നു ഇപ്രാവശ്യത്തെ സെക്ഷനിൽ.
ഓക്കെ, വിഷ്ണു, കൺഗ്രാജുലേറ്ററി മെസ്സേജസ് ആണ് വരുന്നത്. ക്വസ്റ്റ്യൻസ് ഒന്നും ടൈപ്പിൽ കാണുന്നില്ല.
ഓക്കെ ഓക്കെ, ഇത് കുറച്ചും കൂടെ ഇമ്പോർട്ടന്റ് ടോപ്പിക്കാണ്. കുറച്ചുകൂടെ ഒരു ഇതൊക്കെ മീൻസ് പ്രാക്ടിക്കൽ നമുക്ക് ആ ഒരു സിക്ക് പേഷ്യൻ്റ് ആണെന്ന് മനസ്സിലാവുക, വാട്ട് ഈസ് ബിഹൈൻഡ് ഹീമോഡൈനാമിക്സ് ബിഹൈൻഡ് ഇറ്റ് എന്നുള്ളതേ ഉള്ളൂ. ECG ഡയഗ്നോസിസ് മേ നോട്ട് ബി വെരി ഇമ്പോർട്ടൻറ്റ്. അതുകൊണ്ടാണ് ഞാൻ ECG കുറച്ചുകൂടെ കാര്യങ്ങൾ പറഞ്ഞത്. യൂസ്ഫുൾ.
അതെല്ലാം നന്നായി, എന്റെ മാനേജ്മെന്റും പറഞ്ഞല്ലോ.
അതെ, അതിനകത്ത് ഹാർട്ടിൽ എന്താ സംഭവിക്കുന്നതെന്ന് അറിഞ്ഞാലേ നമുക്കത് കറക്റ്റ് ഒരു പിക്ചർ കിട്ടിയാലേ അതുകൊണ്ട് ഒരു സീരിയസ്നെസ് നമുക്ക് മനസ്സിലാവുള്ളൂ. അതുകൊണ്ടാണ് ജസ്റ്റ് ഞാൻ ഇതൊക്കെ ഉൾപ്പെടുത്തിയിട്ടൊരു ഇതെടുത്തത്. ബേസിക്കലി വാട്ട് ഇസ് ഹാപ്പനിങ് ഇൻസൈഡ് AF, EF, PT, when it's a problem, when to treat അത് മനസ്സിലാക്കുന്നുള്ളതാണ്. ബാക്കിയുള്ള ECG ഡയഗ്നോസിസ് മേ നോട്ട് ബി വെരി ഡിഫിക്കൽട്ട് എന്നുള്ളതാണ്.
അല്ല, നമ്മൾ കോമൺ ആയിട്ട് എൻകൗണ്ടർ ചെയ്യുന്ന arrhythmias ആണ് ഇത്.
QT പ്രൊളോങ്ങേഷനും അത് എനിക്ക് വേണമെങ്കിൽ ഞാൻ ഇലക്ട്രോലൈറ്റിന്റെ സമയത്ത് എപ്പോഴെങ്കിലും അത് എടുക്കാം. ഞാൻ കുറെ ECG ഇരിപ്പുണ്ട്. ഇലക്ട്രോലൈറ്റിൽ വരുമ്പോൾ നമ്മൾ എപ്പോഴാണ് സസ്പെക്ട് ചെയ്യേണ്ടത് മേ ബി എന്നുള്ളത്, അത് ഇലക്ട്രോലൈറ്റ്സിന്റെ ക്ലാസ്സിൽ പിന്നെ എടുക്കാം. ഇപ്പം തൽക്കാലം ഞാൻ ജസ്റ്റ് ചെയ്തുകൊണ്ട് ഒരുപാടായി പോകും, അതുകൊണ്ടാണ്.
ഓക്കെ, കുഴപ്പമില്ല. നമുക്കതിൽ വളരെ ഇമ്പോർട്ടന്റ് ടോപ്പിക് ആണ്. അറ്റൻഡ് ചെയ്തവർക്ക് അത് യൂസ്ഫുൾ ചെയ്തിട്ടുണ്ട്. നമ്മുടെ റെക്കോർഡിംഗ് ഇടുമ്പോൾ കുറച്ചുകൂടെ വ്യൂ കിട്ടുമെന്ന് പ്രതീക്ഷിക്കുന്നു. ഏതായാലും നമ്മൾ കോമൺ ആയിട്ട് എൻകൗണ്ടർ ചെയ്യുന്നതാണ്. SVT ഒക്കെ സ്ഥിരം വരുന്നതാണ്. ഏട്രിയൽ ഫിബ്രിലേഷനും വളരെ കോമൺ ആണ്. അതിലും ഒരു EDയില് VT, VF, ടോഴ്സൈഡ് എല്ലാം മാനേജ് ചെയ്യേണ്ടതാണ്. മറ്റൊരു സ്ഥലത്തോട്ട് നമുക്ക് മാനേജ് ചെയ്യാതെ വിടാൻ പറ്റിയല്ല.
സ്റ്റെബിലൈസ് ചെയ്യണം. അതുകൊണ്ട് നമ്മൾ റെഡ് ഫ്ലാഗ് സൈൻസ് നോക്കുക, ECG എടുക്കുക, ഒപ്പം തന്നെ ട്രീറ്റ് ചെയ്യുക എന്നുള്ളതാണ്. അതിനകത്ത് നമുക്ക് യൂഷ്വലായിട്ട് ഇച്ചിരി ഡീവിയേഷൻ വരുന്ന ഇലക്ട്രോലൈറ്റ് അബ്നോർമാലിറ്റീസിലാണ്, QT പ്രൊളോങ്ങേഷൻ ഉള്ള കേസിൽ. അത് സ്പെസിഫിക്കലി നമ്മൾ വാർഡിൽ കിടക്കുന്ന പേഷ്യൻസിനാണ് കാണുന്നത്. അത് ആ സമയത്ത് നമ്മുടെ റെക്കഗ്നീഷൻ കുറച്ചുകൂടെ വാർഡിലെ ECG ഞാൻ കുറച്ചുകൂടെ ഉണ്ട്. ഇതിനകത്ത് ഞാൻ ഇൻക്ലൂഡ് ചെയ്തില്ല. അത് കേൾക്കുള്ള മൊത്തത്തിലൊരു കൺഫ്യൂഷൻ വരണ്ടെന്ന് വിചാരിച്ചിട്ടാണ്. അത് ആ സമയത്ത് ഇലക്ട്രോലൈറ്റിന്റെ സമയത്ത് നമുക്കത് കുറച്ചുകൂടെ ഡീറ്റെയിൽ ആയിട്ട് കാണിക്കാം.
ഡ്രഗ് ഇൻഡ്യൂസ്ഡും
സെയിം ഇത് തന്നെ. ഇത് രണ്ടും കൂടെ വരുമ്പോഴാണ് ബേസിക്കലി ഇത് വരുന്നത്. ഡ്രഗ് കുറച്ചുകൂടെ ഇലക്ട്രോലൈറ്റ് അബ്നോർമാലിറ്റി നമ്മൾ ഏതെങ്കിലും ഡ്രഗ് കൊടുക്കും, ദെൻ ബോർഡർ ലൈൻ വിൽ ഗോ അപ് ടു ഭയങ്കരമായിട്ട് കൂടും, ഒരു VPC വരും, ദെൻ വിൽ ഗോ ടു ടോർസൈഡ്, പേഷ്യന്റ് കൊളാപ്സ് ചെയ്യും. അങ്ങനെയാണ് ആ സിനാറിയോ. പക്ഷെ അത് ഈസിലി പെട്ടെന്ന് നമുക്ക് റെഡിയാക്കാനും പറ്റും. ചിലപ്പോൾ യു ക്യാൻ അവോയ്ഡ് ഓൾസോ ഇഫ് യു റെക്കഗ്നൈസ് ഇൻ ഡേ ബിഫോർ ECG ഓൾസോ അതിന്റെ സൈൻസ് ഒക്കെ കാണും. അപ്പൊ അത് കുറച്ച് ഡീറ്റെയിൽ ആയിട്ട് നോക്കുന്നതുകൊണ്ടാണ് ഞാൻ പിന്നെ അത് പിന്നീട് കാണിക്കാന്ന് പറഞ്ഞത്.
ഓക്കെ, ഏതായാലും നമുക്ക് ഇന്നിച്ചിരി പാർട്ടിസിപ്പേഷൻ കുറവായിരുന്നു. എനിക്കൊന്ന് ഞാൻ ആ ലിങ്ക് ആയിട്ട് കൊടുക്കാത്തതുകൊണ്ട് ആൾക്കാർക്ക് മറ്റേ മീറ്റിംഗ് IDയും പാസ്വേഡും കൊടുത്ത് കയറുന്നതിന്റെ ബുദ്ധിമുട്ടാണോ എന്ന് അറിയത്തില്ല. ചിലര് മറ്റേ മെസ്സേജ് ഇൻവാലിഡ് എന്നൊക്കെ ഇടുന്നുണ്ടായിരുന്നു.
ID തെറ്റി തോന്നുന്നു. 66690 2 തവണ വേണ്ടേ? അതിന് രണ്ടാമത്തെ 2 6 ഉള്ളൂ. ID തെറ്റിന്ന് തോന്നുന്നുണ്ട്.
ID തെറ്റിന്ന് തോന്നല്ലേ? ഓക്കെ, നമ്മളാ ബ്രോഷർ ചെയ്യാൻ കൊടുത്തപ്പോഴാണ് ഞാൻ പിന്നെ ലിങ്ക് ഇട്ട് കൊടുത്തു, മീറ്റിംഗിന്റെ ലിങ്ക് ഇട്ടു. അതുകൊണ്ടായിരിക്കാം എന്നാ ഇൻവാലിഡ് എന്ന് പറഞ്ഞാൽ നമുക്ക് പോസ്റ്റർ ഒന്നുകൂടെ കറക്റ്റ് ചെയ്യാതെ എന്താ പറ്റിയെന്ന് അറിയത്തില്ല. ഓക്കെ ഡോക്ടർ വിഷ്ണു, ഏതായാലും താങ്ക് യു വെരി മച്ച്. ഏതായാലും വളരെ ടൈറ്റ് ആയിട്ടുള്ള സമയത്തിനിടയ്ക്ക് നമുക്ക് വേണ്ടി ഇത്ര സമയം ചെലവിട്ടു. താങ്ക് യു. നമുക്ക് അടുത്ത സെഷനിൽ കാണാം. താങ്ക് യു ഓൺ ദ ബിഹാഫ് ഓഫ് KGMOA Academic Cell and KGMOA. താങ്ക് യു ഫോർ ദ ഓഡിയൻസ്. താങ്ക് യു.
Thank you.
നമുക്ക് ഗുഡ് നൈറ്റ്. ഗുഡ് നൈറ്റ് ടു ഓൾ.
Thank you. Sir.